Myeloma, we've had a lot of advances in the last 10 years. And we've been obviously chipping away at better survival and also better progression-free survival with a number of new agents and combinations, etc. But there's nothing in my mind that has been as impressive as these new immunotherapies. So I do think the game changer is now with chimeric antigen receptor T cells. CAR T cells are here to stay. They are going to change dramatically the way we approach therapy for myeloma in the near future and in the far future. I think it's entirely possible years from now that patients may in fact get a CAR at diagnosis, may get a second CAR at first relapse, may get a third CAR at the next relapse, and then it'll all be immunotherapy, immunotherapy, immunotherapy. The other thing, again, is really new is these bispecific T cell engaging strategies. These therapeutics also can provide very, very deep remissions. We are just at the beginning of trying to find out what is the best cell surface marker to target with these. What is the best binder to CD3 to engage the T cell and to activate it just the right amount, not too much, not too little, to provide the deepest anti-cancer effect. And we're going to come out with therapeutics that are tri-specific, that bind another, that maybe they bring the NK cell into this domain. Maybe it brings the macrophage in this domain. Maybe it just sucks up some of the immunosuppressive cytokines that are in the milieu of where all this action is happening. We're really at the beginning of all this, but the immunotherapy in myeloma, game changer.
The thing that has created the most buzz is the oral hypomethylating agent for AML as a maintenance therapy following induction. That was one of the most important sessions of ASH this year, but hopefully that will be an option for people one day.
The bifunctional monoclonal antibodies, I think those are very exciting agents. There's even one agent or one BiTE agent that can be administered subcutaneously, which makes it much easier to administer as an outpatient. There's limited data so far, but it looks to be quite active. So those are the things that were most exciting to me.
I think the biggest advance in multiple myeloma has been immunotherapy. I'm sure you've heard that already. Because there are so many options for immunotherapy, but not just that, we're getting better at it, meaning we're getting better at managing the patients, we're getting better at understanding why patients aren't responding or maybe why they progress, what to do after that. This year at ASH, I think the biggest abstract for me was the BCMA bispecific engager, which showed an 89% response rate at the higher dose levels. That was something that was with low patient numbers, of course, and short follow-up, but just the fact that people with a median of 5 prior lines of treatment can get that kind of response is pretty remarkable. I look forward to the longer follow-up from it, and I think that now that we have a little bit of that data, we're hungry for more. I really like this drug because it's not continuous infusion, it's weekly and then every other week and then monthly, which I think is way more patient-friendly because myeloma, as I always say, is a marathon, and you have to make sure that the treatments that you give are something patients can tolerate and live with for a long time.
There has been so many that it's kind of hard for me to pick one. I think the most exciting thing are the T-cell engagers. I think in the past several years, we've heard a lot about CAR Ts and how exciting they are. And yes, they are definitely exciting, but the drawbacks of CAR T therapy is really the cytokine release syndrome, the neurotoxicity that can happen, and furthermore, even more important disadvantage is really the manufacturing time with these types of therapies, because this is truly the essence of personalized medicine, that each product has to be manufactured for that particular individual. The T-cell engager therapies are really they're making a lot of buzz because this is off the shelf, so it makes it much more available to patients. It raises the hope that this is an off-the-shelf therapy in a very relapsed setting that our community partners might be able to give as well, as opposed to patients traveling all the way to an academic center or a certified center to get the infusion of CAR Ts. So I think that in the past year has been the most exciting. First, when we saw the Amgen data, and then now more recently the Celgene BCMA T-cell engager data.
The biggest advance is the data for the Keynote 426 and the combination of pembrolizumab and axitinib for patients that represents an immediate advance in terms of what they could receive. And the story has been the same in the last few years. Every year has represented a significant step in the right direction of hopefully one day curing this cancer. Similarly, the availability of avelumab axitinib as an alternate combination for frontline for all IMD categories is another option. So we are making big giant strides at kidney cancer now. The next wave of innovations will have to be though of a different category. In many ways these represent known classes of drugs. We now have to explore the other classes like metabolics and epigenetics to continue to make strides against this cancer.
I think in the field of radiology, artificial intelligence has come a significant way, and it's really exploding. More artificial intelligence is being incorporated into radiology practices for identifying lesions.
I think it's the understanding of the importance of genetics and genomics in prostate cancer. It's as if somebody flicked the switch and went, hey, it's important. And it was emerging, but I think especially in the last year, it's something that's become mainstream. The guidelines have updated that you need to refer to genetic counseling if you're a metastatic prostate cancer patient. Many places around the country already automatically do molecular profiling on patients with metastatic disease. So it changes the way we think about treatment. It changes the way we think about drug development. But that's an exciting advancement because we're impacting real live, treatment decisions, like just constantly moving because of the genetics and genomic information that we get. And it's not a one-time either, right? So as the disease moves on, we're trying to at least do our best to catch up.
Well, just speaking about the trials that I went over, I think clearly the biggest story is how the standard of care for metastatic castration-sensitive prostate cancer really has changed dramatically. So I think offering ADT alone really should not be considered the standard of care, and a patient at least needs to be considered for intensifying therapy. So I think that would be the biggest breakthrough.
Pretty excited about olaparib as a maintenance strategy. I find that it's not in every patient that you're able to consider maintenance therapy. It's especially in pancreas cancer, patients tend to progress before you get to the point where maintenance is an option. But there are a certain percentage of patients every year that they've gone through 8 cycles of therapy and the tumors are no longer shrinking. They're not progressing, but they're no longer shrinking. And so the thought is, do we need to really continue to hit them as hard as we have been hitting them, or can you do a maintenance strategy, sort of what we do in colorectal cancer with Optimox, where you can have sort of these maintenance strategies. And so I'm always been in favor of that. And so I do like seeing that there's some confirmation of something that I've thought a lot about and something that I've tried to put into practice anyway, to have some confirmation that some of these maintenance strategies can be successful.
In the past 3 years, we have seen significant advancement in the CAR T-cell therapies, which has been a remarkable jaw-dropping turnaround in patients with B-cell ALL. Also, I think blinatumomab and its ability to eradicate MRD is very significant. We know that from the transplant literature that patients who had MRD positivity going into transplant have a higher rate of relapse than patients who do not. So attaining MRD negativity may improve allogeneic stem cell transplant results. And in fact, in the BLAST study, they did highlight that patients who had attained MRD negativity with blinatumomab and then moved to allogeneic transplant they had pretty good outcomes. I think over 50% of patients survive, which is good for this population of patients. So I think that blinatumomab and its ability to eradicate MRD is probably the most substantial of the outside of the CAR T discussions that we discussed today. And it's also important to note that the CAR T is only available to those younger than 26. So for our adult patients, I think that would make the blinatumomab study probably the most significant finding that we discussed tonight.
I would say the advent of CAR T and the data that has panned out between the Kite, Novartis product, which is Juliet, and Transcend from BMS, excellent data in the relapsed refractory diffuse large B-cell lymphomas with response rates over 50%. Bispecifics, very exciting in patients who even fail or who have had prior CAR Ts. Combination novel agents with ibrutinib, I should say, with BTKs, BCL2s, and immunomodulators, both doublets and triplets in mantle cell. And in Hodgkin, we are moving more and more into the frontline using a combination of BV-Nivos with very promising results.
Two things clinically, and that was the presentation and the approval of the CLL14 study of venetoclax and obinutuzumab, and then the Elevate-TN study. Both of those gave us into our standard of care armamentarium like additional agents that are very, very effective in patients with CLL.
The biggest advancement is this antibody drug conjugate, BCMA antibody drug conjugate. I think that's the drug that we are waiting for. And the reason is that now we are seeing patients who are daratumumab refractory and they don't do well. So they need drug with a different mechanism of action with less toxicity. So we are waiting for the results from phase 2 clinical trials, and I'm hoping that very soon this drug will be approved as well. Other than that, at ASH, we have seen the results from these bispecific T-cell engagers that target BCMA as well as CD3, and the results are very, very promising. So I think that's great. And as compared to what we have done in past with BiTE antibodies, these drugs do not need continuous infusion. They have been given at a I think frequency of by something like every week. As compared to continuous infusion, so that's great too.
I think the biggest advance in the field has been all of the new agents that have been available for patients, particularly older patients with AML, which is the majority of patients with that diagnosis.